Venkatesh Shivne. He is MRCP from UK, FACP from USA. He had his diploma in diabetology and metabolic. He is a metabolic physician. He is affiliated with the Department of Endocrinology, KIM Hospital, Mumbai. He has vast experience, 20 years experience in the field of endocrinology. He is attached to Jaslok Hospital, Mumbai also. Recently, he has started practice in Wakad area, which is a part of Pune. And he have published more than 36 international peer reviews have been published. Today, he will talk on a very unique topic, management of thyroid disorder in pregnancy, whether it is a concern or hype. आणि नक्कीच ऍट द एंड ऑफ द लेक्चर सगळ्यांना प्रश्नाची उत्तर मिळतील. ऍट द एंड वी विल हॅव सम इंटरॅक्टिव्ह सेशन, वी विल हॅव सम queries. If you have any queries, you can raise in the chat box, and Dr. Mohite sir will take question and answers. And I know that today's lecture will be very interesting. Over to Dr. Shivne sir.
Thank you. Thank you, Dr. Padmanabh Keskar sir, and thank you, Dr. Mohite sir, for the warm welcome and warm introduction. And today I'm going to talk on the thyroid disorders in pregnancy, whether it's a concern or a hype. And what I'm going to show you through some 10 case capsules, what are commonly encountered in our practice. मग असे पेशंट आल्यानंतर usually as a gynecologist or maybe as a physician or maybe as a treating clinician, we advise the patient, Baba, thoda concern hai. So patient immediately ask you, should I terminate the pregnancy? Or should I discontinue the pregnancy? Because that's an easy escape for the treatment. But I think that the punishment should match the crime. If it is the crime of a bigger size, then only punishment should be given. Otherwise, it is not required. So good evening, ladies and gentlemen. And today I'm going to talk about thyroid disorders in pregnancy. Thank you to all the SWAR group of doctors in Wakad, Pune, Pimpale Saudagar area, Dr. Khanna and other team who have warmly welcomed me in Pune. And this is my address, which is reflected in Pune with a contact number. So I'm going to give the important aspects of thyroid disorders are based on the proper iodinization of that particular population. If you see the global statistics, which was defined between the last 20 years till the year of 2006, India is considered as an optimal iodine intake. We know in India, central government has started the compulsory salt iodinization program, and that is consistently happening because the raw salt is considered as not edible, and most of the cities or even villages now the iodized salt is available. That iodinization of the salt has helped in decrease incidence of thyroid goddess. मग गळ्यामध्ये जे सूज वगैरे यायचं त्याचं प्रमाण बऱ्याच अंशी कमी झालंय. But at the same time, we are seeing, if we see your patient's thyroid reports, there are many abnormalities which are seen. Either the TSH is above the range or TSH is very low. The T3 and T4 are in the deranged manner, and we try to manage such patients with the medicines, and it becomes a concern. When such patients are pregnant females, then it's considered as a more challenge because it's not a matter of only one life, but it's a matter of two lives now. So I'm going to take you through some case capsules, and you can see this flow chart where there are some 7 groups which have been mentioned, where in the first group, the TSH is normal, no further treatment is required. Whether TSH is abnormal, every trimester, the TSH monitoring is required. So I'm going to take you through case capsules for all this. So this is a 24-year-old lady who comes with 10 weeks of gestation, and her T3 and T4 were elevated and TSH was low. Now we know, आपल्याला माहित आहे की when TSH becomes low, T3 and T4 goes up. So when the patient came to us on 4th day, we did patients free T3 and free T4, and we found that free T3 and free T4 are absolutely normal. So what we conclude that it's a normal physiological change of the pregnancy. Now, what are the changes which happens to thyroid during pregnancy? You can see from this graph that as the HCG is the hormone which is secreted from the placenta or embryo once it gets implanted on the uterus, immediately in the first trimester, the T3 and T4 increases by 1.5 times of non-pregnant range. So I'm expecting there is a rise in T3 and T4 in the first trimester. At the same time, when we do the free T3 and free T4, that would be either normal or there could be slight decrease. It depends on what type of machine you are using or what laboratory you are referring the samples. Now, what happens to TSH? TSH drops down in the first trimester of pregnancy, and it is expected to be dropped down. Now, why? Because there is a HCG rise. I'll come to that. So HCG, when it goes up, the TSH decreases in the first trimester of pregnancy because there is an inverse relationship between HCG and TSH during the pregnancy. Now, why that happens? Because there is a structural homology between the TSH and HCG hormone. And we know beta HCG, when it's start increasing after pregnancy, upon spot urine pregnancy test karto, once it comes positive, the HCG starts rising. Beta HCG, the first thing which rises, and then urine pregnancy test comes positive after a week. So there is a receptor spillover due to which the TSH becomes undetectable or it becomes detectable on the lesser value. That's why the guidelines said you have to have a trimester specific cutoffs of TSH. Now, this was the old protocol which was defined by American Thyroid Association in 2011. What they said at that time, they have gone through various literature, and in for the first trimester, the second trimester, and third trimester, they said that for that particular population, suppose we are targeting our population in India, we should have a Indian normal data of pregnant females TSH. If that is not available, what they defined as 0.1 to 2.5 should be the TSH range in the first trimester. In the second trimester, it has to be between 0.2 to 3 and 0.3 to 3 in the third trimester. So they have defined the trimester specific cutoffs at that time. Now, what are the challenges? This is a lady who comes to us with a 24, she is a 24-year-old with 10 weeks of gestation. Look at her free T3 and free T4, both are absolutely normal. But the TSH is 4.5. I was expecting the TSH to be low, but the TSH has exceeded more than 2.5 as per this older guidelines. There is a non-suppression of first trimester TSH. So should I label this as a hypothyroidism? The meta-analysis showed this is a meta-analysis of 14 studies. Out of 14, 11 studies have shown that the normal TSH in the first trimester could be above 3. So you should not go by the what American Thyroid Association said of 2.5. It can go above 3. Now these are the Western data. What about India? Dr. Raman Marva from AIMS, he has done the first study in 2008. He has defined the upper range of cutoff in the first trimester of TSH was 5. Mind you, that was a RIA method. Jeba Singh from Manipur has established the cutoffs which on chemiluminescence assay which were far lower than Marva's. In KM Hospital, we did a sample size of 1,200 pregnant women. It is yet unpublished data, but our cutoff is 3.4, which means that if we use the older protocol of American Thyroid Association, we might label more females as hypothyroid in the first trimester. Again, the guidelines revised in 2017 by American Thyroid Association, and they said that for a typical patient in early pregnancy, the TSH upper cutoff should be 4, because they reviewed the literature and they have found that most of the population has the TSH in the first trimester, first 3 months of pregnancy more than 3. If there are reference ranges for that particular laboratory or that particular population, that is fine. But if there is no population data in the first trimester, TSH has to be below 4. What about the second and third trimester? मग दुसऱ्या 3 महिन्यात किंवा शेवटच्या 3 महिन्यात जर प्रेग्नंट पेशंट आपल्याकडे आली तर आपण काय नॉर्मल समजायचं? यूज द अप्पर लिमिट ऑफ नॉन प्रेग्नंट रेंज फॉर दॅट पर्टिक्युलर assay. What it means that if you see the reports of a pregnant lady from Metropolis laboratory or maybe from SRL laboratory, nowadays they are defining the trimester specific ranges for the pregnant female's TSH. So you can refer to that particular sample. So the old paradigm has been changed to new, saying that the TSH of 0.1 to 4 should be considered as euthyroid. But the TSH between 4 to 10 should be considered as subclinical hypothyroidism. Subclinical means there are no clinical manifestations in the patient, and if I check their free T4, it's absolutely normal. If the TSH exceeds more than 10, what we call it as overt hypothyroidism, and definitely all of us know the high TSH in pregnancy is a worrisome problem. So what are the risks associated with high TSH in pregnancy? It has adverse outcomes on the mother as well as the baby. What happens to mother? There is an increased risk of pregnancy loss. There is an increased risk of preterm delivery. There is an increased risk of gestational diabetes or gestational hypertension, preeclampsia, placental abruption, or premature rupture of membrane. Now, what may happen to the baby if the TSH is high? There is an intrauterine growth restriction. There could be a low birth weight, the small for gestation age, low Apgar score. There could be a neonatal death or neurocognitive deficits. So, conclusion is overt hypothyroidism should be avoided in pregnancy, and the recommendation level is A, which is good level of evidence. Let's see about this lady. She is a 31-year-old lady. She comes with 11 weeks of gestation and her TSH is 30. It is way high. So the question comes in our mind, she is 11 weeks pregnant. Should I ask her to terminate the pregnancy? Now let's see what the data says. New England Journal of Medicine in 1999 has excellently published one study on 25,260 pregnant women, of which 62 women were having high TSH and 124 control women were selected. The women who delivered the babies were further followed for 7 to 9 years. The mean TSH in uncontrolled hypothyroidism was 13. And out of the 62, around 12 women were treated and rest of them were untreated. When we see the IQ of the children, and Wisconsin 3 full scale IQ was studied, you can see that the women who are treated for hypothyroidism, their children have the best IQ compared to the children who are treated, who are born to a woman who are untreated are as well as controlled, which means that treating a high TSH is mandatory or it should be the emergency. So would you terminate the pregnancy? The answer is no, because it is 11 weeks of gestation. You should start the treatment immediately. So if the patient asks about you what may happen to the baby, tell the patient that it is better rather than terminating, start the treatment early, because the literature has shown, the studies have shown, starting treatment early improves or rather increases the baby's IQ and neurocognitive functions. Let's come to a subclinical hypothyroidism, where the TSH is between 4 to 10. These are again most of the common reports what we see in our practice. So what may happen in pregnancy? What could be the pregnancy outcomes and what could be the problems with the babies? This is the study which was published in Thyroid in 2016, a subclinical hypothyroidism in pregnancy. It is a systematic review and meta-analysis. You can see that from the figures that there is an increased odds ratio for pregnancy loss, for the preterm delivery, for the premature rupture of membrane, for the placental abruption, as well as neonatal death, which means that subclinical hypothyroidism during pregnancy is associated with multiple adverse maternal as well as neonatal outcomes. Now, one thing question is whether the value of treatment with them with eltroxin or thyroid would help or not was not studied in this particular study. Another meta-analysis of 6 cohort studies with a bigger sample size of 4,400 odd patients has shown that the pregnant women who have hypothyroxinemia, which means low T4, subclinical hypothyroidism, which means the TSH between 4 to 10, and positive thyroid antibodies have low intelligence score, low motor score compared to the control population, which means that yes, subclinical hypothyroidism may have adverse effect on the baby. Now, this is a US data, again on a fairly large sample size of 5,400 odd numbers, where the TSH was defined between 2.5 to 10. What is the risk? There was a considered as an increased odds for or increased risk of pregnancy loss, preterm delivery, gestational diabetes, and preeclampsia in women when the TSH is between 2.5 to 10. Now, in this particular study, they were treating the people with anybody whose TSH was more than 2.5. Did that help? Now, the pregnancy loss, you can see that when the baseline TSH is between 2.5 to 4, the pregnancy loss is more compared to the TSH between 4 to 10, where the study concluded that the benefit of thyroid hormone use and pregnancy loss was observed only in the women with pre-treatment TSH between 4 to 10, which also confirmed that the TSH of 2.5 to 4 should not be treated. It may cause pregnancy loss. Now, the reason is not explained in this particular study. Again, this is an excellent study which was published in 2017 in New England Journal of Medicine, where the women with subclinical hypothyroidism or hypothyroxinemia both were randomized in 2 groups. Around 677 women with subclinical hypothyroidism, half of them were treated with eltroxin or thyronorm, whichever brand you can say, and half of them were kept as control. When they were delivered, their children were followed for the period of 5 years. What happened at the end of 5 years? there was no difference in IQ, no difference in median IQ in both the groups, which means that treatment of subclinical hypothyroidism during the first half of pregnancy did not result in improved cognitive outcomes in offsprings at the age of 5 years. Mind you, the definition of treatment here was more than 4. In the same study, 526 women who had low T4 levels, the TSH was normal, but free T4 was low. They were randomized either with the Eltroxin or Thyronorm compared to placebo, and their children were followed for the 5 years. At the end of 5 years, there was not much of difference noted in the IQ of these children in both the groups, which also means that the treatment of isolated hypothyroxanemia did not result in improvement of cognitive outcome at the end of 5 years. So this lady who is 24-year-old, 10 weeks of gestation, TSH is normal because we take a cutoff of 4 now. Free T3 and free T4 are absolutely normal, but her antibodies are positive. Again, we don't do antibodies, but my request to all of you is in pregnancy, ask your patient to do thyroid functions, and the best one would be not T3, T4, and TSH, but they would be free T3, free T4, and TSH along with TPO antibodies. Those are thyroxine peroxidase. These are thyroperoxidase antibodies, also called as AMA or antimicrosomal antibodies. What is the role of these antibodies in subclinical hypothyroidism? The first study, which was published from China, where the maternal subclinical hypothyroidism and thyroid autoimmunity, also called as antibody positive, and what is the risk of miscarriages. Now, there were 2 groups. There were total 6 groups. In the first group, the thyroid antibodies were negative. In the second group, thyroid antibodies were positive, and the women with thyroid antibodies negative and subclinical hypothyroidism, and the second group, thyroid antibodies were positive and they had subclinical hypothyroidism. The outcome which was studied was miscarriages. Now, what is seen that as the TSH exceeds more than 2.5, linearly, there is an increased risk of miscarriages. The maximum miscarriages have been seen where the TSH is between 5.2 to 10. And the TSH between 2.5 to 5.2, also there was 3.5% increased risk of miscarriages. When we add antibodies here, you can see that the risk increases by more than 5 times, which means that there is a role of autoimmunity in miscarriages. What is seen in this particular study was the gestational age of miscarriages was earlier in all groups with any abnormal TSH and antibody positive. Higher are the TSH levels, earlier is the gestational age at miscarriages. Their second study shown thyroid autoimmunity and miscarriages, a meta-analysis. This study has shown 22 studies, of which 14 are core studies and 8 are case control studies. There was a presence of thyroid autoimmunity associated with increased risk of spontaneous miscarriages even in euthyroid women. So the women, their thyroids are less, TSH is less than 4, but antibodies are positive. Yes, there is an increased risk of miscarriage. Now, the second is thyroid antibodies and increased risk of preterm delivery. The thyroid antibodies positive has shown increased risk of preterm delivery, which means that autoimmunity does play the role in bad obstetric outcome. Now, this lady she is a 24-year-old and she has 10 weeks of gestation, but her antibodies are positive, as I have discussed. And what is the role? We all know antibodies are associated with bad outcomes. So there is an increased risk of miscarriages as well as preterm deliveries. Should we treat these ladies? Let's see what the data says. Now, the first study, which was done in antibody positive patients who are euthyroid, has divided these groups into 3 arms. The first one was antibody positive patients who were treated with thyroxine. Second was antibody patients who were not treated. And third was antibody negative patients who were just observed. You can see in the yellow that the women who have antibody positive, they have higher range of TSH more than 3, I would say, in the first or second or third trimester. Now, what is the outcome? The antibody positive women who has not been treated have increased risk of miscarriages as well as preterm delivery. So, which also means that if we treat the patients with antibody positive women with subclinical hypothyroidism or even the TSH between 2.5 to 4, it lowers the chances of miscarriages and premature delivery. So, what the algorithm will define now? Let's start about the new algorithm. Any TSH more than 4, even though it is 4 to 10 or it is more than 10, it requires treatment. Subclinical hypothyroidism women, pregnant women whose TSH is more than 4 needs to be treated. How do you want to treat them? Start with a dose of either eltroxin or thyronam. What should be the dose? 1 to 1.6 microgram per kg of body weight, which is for a 60-year-old lady around 62.5 to 75 micrograms. Now 0.1 to 2.5 of TSH requires no treatment. Now what is the concern about 2.5 to 4? Because the American Association has increased the dose of the level of TSH cutoffs from 2.5 to 4. How does this needs to be challenged? If the TSH is between 2.5 to 4, please do the antibodies. If the antibodies are positive or there is a bad obstetric history or increased past history of miscarriages, start treatment immediately. What should be the dose? Closer to 25 or 37.5 or 50 micrograms per day. However, if the TSH is between 2.5 to 4 and antibodies are negative, they don't need treatment. So this is the fourth group which requires treatment. Now, this is a classical lady who is already having hypothyroidism, and she last presented 3 months before. Her TSH was normal at that time, and suddenly she became pregnant and she presented with a TSH of 8.4. Now we know she is a case of primary infertility. Her antibodies are positive. Her TSH was normal. She was on 50 microgram. So how to manage these patients? The preconception thyroid dose should be increased to achieve TSH less than 2.5. So if any hypothyroid lady comes to your clinic for a treatment of infertility, the first thing is up titrate the dose of thyroxine to achieve the TSH below 2.5. Usually in pregnancy, it is seen that the thyroxine requirement increases by 30 to 50%. The TSH should be done every 4 weeks during the first half of pregnancy and at least once between with the 26 to 32 weeks of gestation. Following delivery, the dose of thyroxine or LT4 can be reduced to preconception level. म्हणजे गरोदर व्हायच्या आधी जेवढा डोस होता तेवढ्या डोसवरती आपण डिलिव्हरी झाल्यानंतर वापस येऊ शकतो. Neonatal thyroid function is a part of universal screening, and I'm sorry to say that even in a big hospitals and big metropolitan cities, there is a no universal screening for neonatal thyroid function test. Please ask the gynec. I would request the obstetricians and gynecologists that every delivery, whatever the child gets, on at least on birth, if it is not possible, from the cord blood or either in the second day of life or 4th day of life, you can ask the parents to do the thyroid function of the baby. Now, this lady, who is a 31-year-old, she comes to us with 10 weeks of gestation. She has high T3, high T4, and very low TSH, also called as symptoms of hyperthyroidism. Because as in hyperthyroidism, T3 and T4 वाढतो आणि TSH कमी होतो. Then we did her free T3 and free T4. Her free T3 was also increased, free T4 was also increased. Now, this is called as hyperthyroidism. Again, it is the most challenging. How to manage hyperthyroidism in pregnancy? Or what are the causes? The first one common is gestational transient thyrotoxicosis. It's very, very common and usually it's a benign problem. Second is Graves' disease, also called as hyperthyroidism. The third is considered as thyroiditis, which is called as a leakage of the hormone. The fourth is autonomously functioning thyroid nodule. Now, what is the impact of this hyperthyroidism? She's a 28-year-old, 10 weeks of gestation. The free T3 and free T4 were pre-pregnancy normal. At 6 weeks, the free T3, free T4 is high. Now, one thing we have to keep it in mind that in pregnancy, we can't do radionucleotide studies. We can't do technetium scan. We can't do radiouptake scan. So free T3 and free T4 hormones are high. The only best test where we can rule out the hyperthyroidism is TSH receptor antibodies. So if the TSH receptor antibodies are negative, we can conclude that this is a temporary problem called as gestational transient thyrotoxicosis. What is the management? No treatment. You can just observe. Within 4 weeks, the T3, free T4 has dropped down. Within 10 weeks, the function comes to normalcy. Usually, gestational transient thyrotoxicosis women comes with hyperemesis gravidarum. खूप उलट्या होतात, खूप मळमळ करतं, अतिशय जेवण जात नाही. Those become very sick. These are the women who are high risk of development of gestational transient thyrotoxicosis. Why this happens? It happens because of the HCG hormone secreted from the placenta. It is HCG mediated. The severe form is called as hyperemesis gravidarum. 30 to 60% of women have high T4. It requires no treatment. Some of the doctors, they start anti-thyroid medicine, but we have to be very careful. It is unnecessarily not required. Very severe patients we can give them. Now, what is the difference between Graves hyperthyroidism and gestational thyrotoxicosis? म्हणजे पेशंटला हायपरथायरॉइडिझम आहे की HCG मुळे झालं, आपण कसं डिफरन्शिएट करणार? Go back to the symptoms pre-pregnancy. If there are, ask the patient whether the patient has weight loss, whether the patient had tremors, whether the patient had palpitations prior to conception, prior to pregnant राहण्याच्या आधी जर symptoms असतील तर ते Graves आहेत. Symptoms during pregnancy, persistence, they become persistent in Graves' disease. However, gestational thyrotoxicosis, they don't get those severe Graves' disease symptoms. Nausea and vomiting is very, very common in gestational transient thyrotoxicosis, which is not the part of Graves' disease. Goiter, eye changes, ophthalmopathy, these are the changes which are seen in Graves' disease. The antibodies are positive in Graves' disease. And if we do the ultrasound, if there is an increased vascularity, it is Graves' disease. If it is normal scan, it is gestational thyrotoxicosis. So this lady who is 25-year-old, 24 weeks of gestation, and she pre-pregnancy thyroid report was normal. 14 weeks her TSH was normal. At 24 weeks her free T3 and free T4 are high. Thyroid receptor antibodies are positive. Now this is a big challenge for us to manage because she has de novo नव्याने झालेला Graves disease आहे गरोदरपणामध्ये. So she is de novo hyperthyroidism in pregnancy. How to manage? TSH receptor antibodies are positive. Because she came to us in 24 weeks, we started her on neomercazole. Within 28 weeks, up to 28 weeks, within 4 weeks, her free T3, free T4 came to normal. आणि मग आम्ही neomercazoleचा dose कमी केला. So Graves disease in pregnancy. This is another example where the free T3, free T4 TSH was high to a patient who was planning to become pregnant. She was only on 2.5 milligram and she came to us in October, then she came to us in December. But जेव्हा ती आमच्याकडे आली, she was not diagnosed as she is pregnant. And so because her TSH was low, we increased the dose of neomercazole. Then she came to us with 6 weeks of pregnancy. We stopped neomercazole and started the patient on propylthiouracil, which is 100 milligram 3 times in a day. And we try to control the free T4. We try to control the free T4. We are not looked up to free T3 or TSH. Just look for management of free T4. So Graves disease in pregnancy, or also called as hyperthyroidism in pregnancy, again has a bad obstetric outcome. There are 45% chances of abortion, placenta abruptio, congestive cardiac failure, thyroid storm, preeclampsia, premature delivery, or stillbirth. But the good control of toxicosis improves all outcomes. Now, how to treat? Either patient can be started on propylthiouracil or neomercazole, depending on when the patient is coming to you or which trimester patient to coming to you. The efficacy is same. However, we have to understand that propylthiouracil is associated with 2 to 3% of increased risk of liver failure. On the contrary, neomercazole is associated with aplasia cutis or clonal atresia. The chances are 3 to 4%. Now, what should be the drug of choice? Jar patient पहिल्या 12 आठवड्यापर्यंत, if the patient has come for first 12 weeks, start the patient on PTU. If the patient presented to you in second or third trimester, methimazole should be started. Now, these are the 2010 guidelines published in endocrine practice that whenever the patient who is hyperthyroid already on neomercazole comes to you and says that she is pregnant, stop neomercazole, shift the patient to propylthiouracil. After the first trimester is over, again start the patient on methimazole or neomercazole. Start with the lesser dose. Why? Because the thyroid receptor antibodies, the titer decreases over a period of time. It is also said that pregnancy is a boon to pregnant Graves disease women. Somehow they get cured during the course of pregnancy. Why? We don't know. The exact reason we don't know, but that hyperthyroidism usually gets cured. The dose should be used in lowest possible. Monitor thyroid functions 3 to 4 weekly. Try to maintain the free T4 higher range of normal. फ्री T4 चा रेंज जो असतो त्याच्या लॅबच्या नॉर्मल रेंज मध्येच ठेवायचा, पण थोडा हायर साइडला ठेवायचा. खूप जास्त जर फ्री T4 लो केला तर बेबी मे डेव्हलप हायपोथायरॉइडिझम. Now don't look for or do not try to normalize free T3. Never try to normalize TSH because you are not going to achieve anything. So free T4 should be only parameter to be monitored. Now, what are the indications for surgery? The women who are having high dose PTUचा dose जर 300 पेक्षा जास्त असेल or methimazole dose is more than 20 milligram, who are inadequately controlled, they are the good candidates for surgery. If any woman develops side effects of PTU or methimazole, they are the good candidates for surgery. What is most important is if you are suspecting hyperthyroidism, TSH receptor antibody should be done at diagnosis itself and then do every third trimester. In the third trimester, because it predicts the risk of neonatal toxicosis and postmortem recurrence. What may happen to the baby? जर मम्मीला जर आईला जर ग्रेव्स डिसीज असेल तर बाळाला काय होऊ शकतं? Baby also may develop toxicosis because of TSH receptor antibodies transfer to the placenta. So how to monitor the baby? Ultrasound 20 to 20 weeks and every monthly. Look for fetal goiter. A good radiologist is required, good sonologist is required. Ask them to look for the goiter of baby's goiter for the baby. Tachycardia, the heart rate, if it is exceeding more than 160, for fetal heart rate is exceeding more than 160. Growth retardation, if it is seen, oligohydramnios, if it is seen, or if there is accelerated bone maturation seen, these are the parameters needs to be monitored for the baby. How to treat fetal toxicosis? Treat mother, baby will get automatically treated. How to monitor them? Try to control the fetal heart rate between 120 to 160. Now, hyperthyroidism in pregnancy is literally deleterious for the baby as well as for the more for the baby. There is a placental transfer of TSH receptor antibodies which may cause neonatal toxicosis. There is a placental transfer of antithyroid drugs which may cause fetal hypothyroidism at birth. There could be placental transfer of maternal thyroxine which may cause fetal central hypothyroidism. Now look for this lady, very illiterate patient. ती गावाकडून आली होती आमच्याकडे, 19-year-old. She was having Graves' disease for 2 years. She was on highest dose of neomercazole, 50 milligram. We are actually planned radioactive iodine in this lady, but she lost to follow. When she came back to us, she was 22 weeks pregnant. And at 22 weeks, her TSH was uncontrolled, even though free T4 was normal, and she was taking 60 milligram of neomercazole. The doctor from her rural area has increased the dose. We decreased the dose of 60 to 40, and on 40 milligram, her TSH was okay. Again, once we reduced the dose, her thyroid function worsened. Then we decided that let's monitor the baby only. So we tried when the fetal heart rate was 170 beats per minute and baby fetal goiter was seen on ultrasound, we tried to increase or decrease the dose and try to monitor the fetal heart rate only. What happened? This lady again absconded. She lost to follow-up and she delivered at home. Now look at the baby. The baby was brought to us on the 20th day. The baby was having high crying spells. The baby's heart rate was 140 and the weight was 2 kg. When we did the baby's test, the TSH was suppressed, so it was a neonatal toxicosis. We started the baby only on 1 milligram of neomercazole, and within the next 30 to 45 days, the thyroid function came into normalcy. So neonatal toxicosis, ideally, a good obstetrician and good pediatrician should pick it up in the third trimester itself. Just do TSH receptor antibodies. Higher is the titer of TSH receptor antibodies, higher is the risk for neonate to develop toxicosis. The baby may or may not be toxic at birth depending on antithyroid medications. It disappears in few weeks. But after the birth, the thyroid receptor antibodies disappear. So baby doesn't require lifetime treatment, but after 3 to 4 months, the thyroid functions may come to normal. Now, the second is most concerned is placental transfer of maternal thyroxine. If mother is hyperthyroid, naturally mother's thyroid hormones are high. The same thyroid hormone goes to the baby and try to suppress the baby's TSH from the pituitary may cause hypothyroidism. Now, this lady who is 25-year-old, she comes with a Graves' disease at 10 weeks and she was on advised antithyroid drug, but she absconded. She lost to follow-up. When she presented to us at 37 weeks, she has pregnancy-induced hypertension and she presented with congestive cardiac failure. Now, we started this patient because of this patient already 37 weeks, the patient was posted for lower section, cesarean section. Baby was delivered. Baby developed jaundice at day 3 of life, and baby was having low TSH at birth. Usually, the TSH should be on the upper range of normal at birth, but the TSH was low. So we repeated the test after 2 months, and we diagnosed that the T3 was also low, the T4 was also low, the TSH was also low. The baby was diagnosed as neonatal central hypothyroidism, and the baby was started treatment. Now, what about the breastfeeding women after delivery if they are on neomercazole or methimazole? Methimazole is considered safe in breastfeeding. The thyroid functions in breastfeeding when the mothers are treated with 20 milligram or less than that usually is acceptable. But the only recommendation is first the mother should feed the baby and then take neomercazole. So after taking neomercazole, don't do the breastfeeding, and try to keep a gap of 5 to 6 hours after taking neomercazole, so that there is a little excretion in the breast milk of neomercazole, but found to be safe up to the dose of less than 20 milligrams. This is the 28-year-old postnatal lady who comes to us. In pre-pregnancy, thyroid functions was normal, and even in pregnancy, thyroid functions were normal, but after delivery, her thyroid functions were elevated. Now, what we did antibodies. We did antibodies and found that this is thyroiditis. This is also called as postpartum thyroiditis. Usually, it doesn't require treatment. It requires only conservative treatment with the beta blockers like Ciplar or propanolol or metoprolol. After 2 months, their thyroid functions came to normal. But what happens to them that these women further develop hypothyroidism. So after 4 months, when she came to us, she developed hypothyroidism and she was started with 50 microgram of eltroxin. So what happens in postpartum thyroiditis that after delivery, they will come to you in hyperthyroid reports that causes that they don't need a treatment like neomercazole or PTU. Just observe them. Then they go into euthyroid phase. After that, they go into hypothyroid phase, and after that, they go into recovery phase. Only during that 6 months to 1 year of hypothyroid period, they require L-toxin. After that, it can be stopped. So with all this, ladies and gentlemen, what we learned today, that the older paradigm have been changed to new, with mentioning the TSH defined cutoffs as between 0.1 to 4 and 4 and above. 4 to 10 is subclinical hypothyroidism, more than 10 is overt hypothyroidism. What about treatment? Any TSH more than 10 should be treated. What about 0.1 to 2.5 of TSH? They don't need treatment. What about if the TSH is between 2.5 to 4? Do the antibodies. If the antibodies are positive, or there is a bad obstetric history, or there is a history of infertility or miscarriages, start the woman on 50 microgram of eltroxin or Thyronorm. If the antibodies are negative, they don't need treatment. What about hyperthyroidism? The gestational thyrotoxicosis is the most common form. So don't presume that every gestational thyrotoxicosis is Graves' disease, and don't start PTU and neomercazole unnecessary. How to differentiate that? You can just do a TSH receptor antibodies, because you can't do radionucleotide scans in pregnant women. This HCG mediated gestational transient thyrotoxicosis is self-limiting. It requires no treatment. And it is mentioned that even though the Graves' disease in pregnancy presents to you, in the first trimester, you should treat them with propylthiouracil 100 milligram 3 times a day. When the woman comes in second trimester, shift from propylthiouracil to neomercazole, but try to reduce the dose of neomercazole. Lowest possible dose should be used. And when you are monitoring a patient who is Graves' disease and pregnancy, just monitor them with free T4. Try to keep the free T4 on the upper range of normal. Never try to normalize TSH, neither free T3. So what is the risk of hyperthyroidism in pregnancy? In hyperthyroidism, there is a placental transfer of TSH receptor antibodies that may cause neonatal thyrotoxicosis. So baby's viability and baby's monitoring is very essential. Placental transfer of antithyroid drugs may cause fetal hypothyroidism. Again, the monitoring is essential. Most important is the placental transfer of maternal thyroxine may cause fetal central hypothyroidism, which means that a good team of endocrinologists, a good team of gynecologists, radiologists, and neonatologists is required to manage the thyroid disorders in pregnancy. But keep it in mind that don't get scared. Don't go with the hype of what it is said and go ahead and discontinue or do the abortion or discontinue the pregnancy. If the maternal and fetal outcome is excellent, it is if the patient is well managed. With all this, I would like to thank all of you for patience listening, and thank you very much. In case you have any questions, I will coordinate with Dr. Padmanabh sir to answer them. Thank you very much for patience listening again. Over to you, Padmanabh sir. Thank you.
मोहिते सर जरा क्वेश्चन घेता का? मी 2 मिनिटात जॉईन होतो. आहे ते जॉईन?
ओके सर. ओके आहे. ओके. ओके, थँक्यू सर. थँक्यू व्हेरी मच. हँड रेज कोणी केलं? शेजार सर, तुम्हाला काय विचारायचं आहे विचारा. अनम्यूट करा ना, विचारा.
हॅलो हॅलो.
येस,
बोला.
हा, रुटीन ANC चेकअप मध्ये फर्स्ट ट्रायमेस्टरला TSH हे रुटीनली करायचं का सिम्पटम आल्यानंतरच करायचं आणि
It is
रिपीट.
good question, sir. Now, this also tells me that who are the female who are high risk for development of thyroid diseases. Good question, sir. I would put it in this way. They are not infertility patients. They are coming to you in the first trimester. So who are the high risk for where the TSH should be done? There is a prior history of thyroid disease. There is a family history of thyroid disease. Type 1 diabetes girls when they become pregnant. History of PCOD, if any in the past. Obesity. Family history of thyroid illnesses. Any prior history of amiodarone, like the drugs which have been used routinely for atrial fibrillation, if there is a consumption of such drugs, then thyroid functions are mandatory. As of now, there are no guidelines that there has to be routine TSH screening in the first trimester. But if you think that there is an increased suspicion, if elderly woman comes to you after the age of 31, it is better to screen all elderly pregnant women for thyroid function test.
तर नॉर्मल आला असेल तर रिपीट कधी करायचं सर?
Third trimester. As I have said, if first trimester is normal, repeat in the third trimester.
योगेश
सर गुड इव्हनिंग.
Good evening.
म्हटलं आपण आता हे जे करतोय सर, आता तुम्ही सांगितलं का फ्री T3, T4 आणि TSH करायचं. तर
Yes,
सर
sir.
सगळ्यात महत्वाचं आपण जे फास्टिंग आणि फ्री करतो याच्यातला डिफरन्स काय? दुसरी गोष्ट ऑक्झिलरी मॅनेजमेंट मध्ये आपण काय सांगितलं पाहिजे डाएट रेजिमेंट संदर्भात काय की हायपोथायरॉइडिझम मध्ये आपण मोस्टली कोबी फ्लावर सोयाबीनचं तेल आणि हे बंद करत असतो असे अनेक वेळा एंडोक्राइनॉलॉजिस्ट सांगतात. तर त्याचं किती हे आहे सर? किंवा हायपरथायरॉइडिझम साठी काय आपण डाएट अँड रेजिमेंट कन्सिडर केलं पाहिजे?
ओके सर, थायरॉइड हॉर्मोन हा मोस्टली बाउंड फॉर्म मध्ये असतो. 80% हा बाउंड फॉर्म मध्ये असतो आणि तो एका
Yes, sir.
प्रोटीनला बाउंड असतो ब्लड मध्ये. त्याला थायरोग्लोबिलिन म्हणतात. सो इट गेट्स अटॅच्ड. जेव्हा शरीराला गरज असते तेव्हा तो रिलीज होत जातो. त्याला म्हणतात, जो रिलीज होतो त्याला म्हणतात फ्री T3 आणि फ्री T4. तसं बघायला गेलं तर फ्री T3 आणि फ्री T4 हे मोस्ट स्टर्डी लेवल्स आहेत. ते युजली फ्लक्च्युएट होत नाहीत प्रेग्नन्सीमध्ये. त्यामुळे ते टेस्ट केलेले अधिक चांगले. हा पहिला भाग, तुमचा पहिला प्रश्न. दुसरा आहे तुमचं की कोबी किंवा इतर काही डायटरी रेजिम्स. आता हे कोबी असेल, सोयाबीन असेल, दीज आर कॉल्ड एज ग्वायट्रोजेन्स. ग्वायट्रोजेन्स म्हणजे थायरॉइडचा आकार वाढवणारे पदार्थ. जर फिमेलला ग्वायटर नसेल तर अननेसेसरीली काही डायटरी रिस्ट्रिक्शन करण्याची गरज नाही. जर फिमेलमध्ये ग्वायटर असेल, तिला व्हिजिबल ग्वायटर असेल, तर आपण सांगू शकतो की तुम्ही कॅबेज असेल, सोयाबीन असेल किंवा इतर काही ग्वायट्रोजेन्स असतील ते तुम्ही टाळले पाहिजे प्रेग्नन्सीमध्ये.
येस सर, येस. थँक्यू.
थँक्यू.
शाह मॅडम.
Namaskar. Thank you so much for the informative session, sir.
Thank you.
I had the hypothyroid, and when I was conceived, and without any proper treatment, I got delivered a baby. The doctor started my thyroid medicine with 25 microgram of Thyronorm at the fourth month, I guess, and I had a lot of vomiting and nausea. So after the baby was delivered, she does not have any problem. But are there any chances of getting any other thyroid-related issues in her later life? I am not sure how much.
I would, excellent question, madam. We have done a study.
I had put on like 25 kilo during that, unlike other ladies. Thank you.
I will tell you what is the family history of autoimmunity. We have done an excellent study in KM Hospital where we have studied the first degree relatives of our thyroid patients. And it was a big sample size. Again, it was more than 1,000 patients, relatives, blood sample we collected just to look for their thyroid dysfunction and thyroid antibody levels. What we have noticed that 33% of first degree relatives, which means 1 in 3 relative have this antibody titer positive, which means that today, even though they are normal, in future there is an increased risk of development of thyroid problem. So what is required and advised here that if your child who is if you monitor the growth parameters, if the growth parameters are as per the norms which are defined by pediatricians, no active testing is required. However, if you think that he is putting on weight, or there is a stunted growth, or maybe there are some symptoms, you can just do thyroid function test along with the antibodies, and then you can take a call with your pediatricians. Just try to observe the growth. That is most important.
Sir, one more question. I have a patient which is a small girl, like age 11, and unlike other siblings, she has not put on her height as well as weight. She looks like a 5-year-old girl, and her TSH is really high. famous doctor has advised her to go for radioactive treatment. I'm not sure about, sir, how to proceed. So could you, sir, please help?
I would advise that the radioactive iodine initially was considered as not safe in children. Now there is enough data available about use of radioactive iodine in young girls and adolescent girls also. Now, what is recommendation that initially they were hesitant to give it to unmarried girls, that they were thinking that radioactive iodine may cause problem to the baby, but there are extensive data. The only concern is after radioactive, any young girl or young woman also can take radioactive iodine if it is advised. Only condition is for at least after radioactive iodine, at least for 6 months to 1 year, she should not conceive or she should not become pregnant. That's the only thing. So if this girl has been advised radioactive iodine for the permanent ablation of the thyroid gland, I think she should go ahead with it.
We
Thank
will
you
take
so
some
much, sir.
question from chat box
Yes, sir.
because there is one question. Can thyroid medication be stopped after delivery or patient becomes normal its own or need treatment for whole life?
No, sir. Usually, it's a good question. Any subclinical hypothyroidism, when treated in pregnancy, usually they don't need treatment after pregnancy. That's what I have shown in my slide, so that the treatment can be stopped after pregnancy. However, if the patient is with subclinical hypothyroidism and her antibodies are positive, usually they require to be continued because it is called as autoimmune thyroid illness, which is likely to be there lifelong. So antibody estimation would help you whether to discontinue the treatment or whether to continue the treatment.
Okay. And one more question is when to ask for T3, T4 or pre-T3, pre-T4 means shall we ask each and every patient to do the pre-T3, T4
No,
or not?
in otherwise, because what I said that pregnancy is the only condition where in the first trimester the T3 and T4 increases by 1.5 times. So that will give you the misleading results. That's why the pregnancy is the condition where the more sturdy assays like free T3, free T4 and TSH should be used. Even in non-pregnant women or in males or any other person, you can do T3, T4, TSH. There is no problem.
Okay, anybody have questions? You can raise your hands.
हॅलो
Yes, sir.
हा सर डॉक्टर सुहास पावसकर फ्रॉम कणकवली.
Yes, sir.
सर प्रत्येक डिलिव्हरी नंतर बाळाचं बच्चेचं थायरॉइड फंक्शन करावंच पाहिजे का?
It is recommended, sir. Most of us we do, but it is recommended. See, one data has shown that the better screening tools of neonatal hypothyroidism will help the boy to not only for his growth but also for his improvement in IQ. Otherwise, they will become creatine. If we miss even we miss one creatine, it's a big loss to the society or to the family. So it is ideal that neonatal thyroid monitoring or neonatal thyroid screening should be done. In KM, we are routinely doing neonatal thyroid screening. It is advised, even central government is encouraging people to do neonatal thyroid screening because earlier you pick up the problem in the newborn, easier to manage.
जर जरी मदर नॉर्मल असेल तरी करणं गरजेचं असतं का?
Baby, even though it is normal, as I said, subclinical problems can be picked up at early age. So it is called as a universal neonatal thyroid screening program. There is no excuse for that, sir. Like we do for G6PD deficiency at birth. Some of the centers are doing G6PD deficiency. Some of them are screening for blood grouping typing and hemoglobin. So similar way, you don't have to prick the baby. Just collect some serum from cord blood and send it for the estimation. Even that is also fine.
एक गोष्ट लक्षात घ्या सगळ्यांनी की बरेचदा आपलं कन्फ्युजन होतं की नॉट ओनली इन प्रेग्नन्सी आपल्याकडे एरवी सुद्धा पेशंट कधी थायरॉइडचा रिपोर्ट घेऊन येतो आणि पेशंटचं मार्जिनली रेंज असतं TSH मे बी 6.5 असतं 7 असतं आणि आपण विदाउट डुईंग एनी फर्दर इन्व्हेस्टिगेशन डायरेक्टली आपण स्टार्ट करून देतो ट्रीटमेंट. सो सरांनी सांगितल्याप्रमाणे अप टू 10 जर का लेवल असेल TSH ची सो इट इज कॉल्ड एज सबक्लिनिकल हायपोथायरॉइडिझम. तिथं तुम्हाला ट्रीटमेंटची इमिजिएटली गरज नाही अनलेस अँटीबॉडीज आर प्रेझेंट. इफ इट इज मोर दॅन 10 TSH जर का 10च्या वरती असेल तर डेफिनेटली ट्रीटमेंट लागणार. सो मी नॉर्मल इंडिव्हिज्युअल मध्ये म्हणतो, प्रेग्नन्सी मध्ये नाही सांगितलं. प्रेग्नन्सी मध्ये सरांनी काय सांगितलं की अप टू 2.5 जर का TSH असेल तर देर इज नो नीड ऑफ एनी ट्रीटमेंट ऑर एनी इन्व्हेस्टिगेशन. 2.5 to 4 जर का TSH असेल तर त्या ठिकाणी तुम्हाला थायरॉइड अँटीबॉडीज केला पाहिजे आणि देन यू हॅव टू डिसाइड की वेदर पेशंट रिक्वायर्स ट्रीटमेंट ऑर नॉट. जर का थायरॉइड अँटीबॉडीज निगेटिव्ह असतील तर नो नीड ऑफ ट्रीटमेंट. 4 पासून 10 पर्यंत ज्याला आपण एरवी सबक्लिनिकल हायपोथायरॉइडिझम असं म्हणतो आणि आपण ट्रीट करत नाही, तर ते मात्र आपल्याला प्रेग्नन्सी असेल तर ट्रीट करणं भाग आहे. बरोबर ना सर?
येस सर, येस सर, करेक्ट, बरोबर आहे.
समरी. अजून कोणाला क्वेश्चन्स आहेत?
हॅलो.
हा मॅडम.
हा सर, हायपरथायरॉइडिझम मध्ये आपण कसं मॅनेज करावं लागेल पेशंटला, की मेडिसिन एक्झॅक्टली चालू करायचं की त्यामध्ये पण आपल्याला अँटीबॉडी टेस्ट करावं लागेल हायपरथायरॉइडिझम?
हायपरथायरॉइडिझम मध्ये मॅडम सगळ्यात पहिले तर आपण TSH रिसेप्टर अँटीबॉडी टेस्ट करायची. ती थोडी कॉस्टली आहे. पेशंटला कन्व्हिन्स करायला लागेल की TSH रिसेप्टर अँटीबॉडी जर पॉझिटिव्ह असेल तर पेशंट कन्फर्म हायपरथायरॉइडिझम आहे. समजा जर ती निगेटिव्ह असेल तर समजायचं की ते पेशंटचे जे वॉमिटिंग वगैरे असतात किंवा इतर सिम्पटम असतात ते HCG मुळे आहेत आणि ते 4थ्या महिन्या किंवा 5व्या महिन्यापर्यंत ते आपोआप कमी होणार आहेत. त्याला गोळीचं गरज नाही. पण पेशंटचं जर TSH रिसेप्टर पॉझिटिव्ह आलं आणि पेशंट पहिल्या 12 आठवड्यात जर तुमच्याकडे आला तर PTU टॅबलेट चालू करायची 100 मिलीग्राम ट्वाइस, 2 टाइम्स टू 3 टाइम्स. त्यावेळेचा जो रिपोर्ट आहे त्याच्यानुसार पहिल्या ट्रायमिस्टर संपला किंवा पेशंटला 14वा ते 15वा आठवडा सुरू झाला की PTU बंद करून निओमर्कोझॉल चालू करायची. पण डोस शक्यतो कमी ठेवायचा. चालू करताना शक्यतो 10 ते 15 मिलीग्रामच वापरायचा, त्यापेक्षा जास्त वापरायची गरज नाही. कारण मी असं सांगितलं की हायपरथायरॉइडिझम हे गरोदर बायकांसाठी एक वरदान आहे. ऑटोमॅटिक ते रेफरन्स रेंजमध्ये येत जातं. त्यामुळे मोस्ट ऑफ द ग्रेव्ह डिसीज किती जरी सिव्हिअर असतील तरी त्यांचं थायरॉइड फंक्शन 3rd ट्रायमिस्टर पर्यंत आपोआप नॉर्मल येतं आणि पेशंटला फार कमी डोस लागतो. त्यामुळे डोस वापरताना एकदम कमी डोस वापरायचा आणि सगळ्यात महत्वाचं मॉनिटरिंग करताना T3 T4 करायचं नाही. फ्री T3 आणि फ्री T4 करायचं, पण फक्त फ्री T4 नुसार डोस बदलत राहायचा. फ्री T4 ची व्हॅल्यू किती ठेवायची? वरच्या लॅबची जी नॉर्मल रेंज आहे त्याच्यामध्येच ठेवायची, पण वरच्या साईडला ठेवायची, खालच्या साईडला ठेवायची नाही. कारण खालच्या साईडला जर आपण ठेवतो तर बाळाचे थायरॉइड सप्रेस होतं आणि बाळाला हायपोथायरॉइडिझम व्हायचे चान्सेस जास्त असतात.
आपल्याला बऱ्याच काही लोकांनी विचारलंय की रेकॉर्डिंग अवेलेबल आहे का? त्याचं युट्यूब वरती पण स्ट्रीमिंग होत आहे आणि रेकॉर्डिंग हे अवेलेबल राहणार आहे. त्यांना काही कारणाने आज अटेंड करता नाही आलं किंवा पूर्ण सेशन ऐकता आलं नाही. सगळ्यात महत्वाचं लक्षात घ्या की ऍज अ फॅमिली फिजिशियन तुमचा सगळ्यात महत्वाचा रोल, यू मे नॉट ट्रीट दिस काइंड ऑफ पेशंट्स. ओके, त्याच्यासाठी तुम्हाला इंडोक्रायनॉलॉजिस्ट लागेल किंवा सुपर कन्सल्टंटची मदत घ्यावी लागेल. पण मेन थिंग इज तुम्ही अर्ली पिकअप करू शकता पेशंट. जे सरांनी मध्ये बरेच सांगितले की पेशंट ड्युरिंग प्रेग्नन्सी ते त्या ठिकाणी ट्रीटमेंट सोडून बाजूला गेले. ते कुठे गेले? ते शेवटी त्यांच्या फॅमिली फिजिशियन कडे गेले असतील. तेव्हा तुम्हाला या पेशंटला त्या ठिकाणी कन्व्हिन्स केलं पाहिजे. त्यांना त्याची गरज काय आहे हे तुम्हाला सांगणं महत्वाचं आहे पेशंटला. त्याच्यामुळे तुमचा रोल हा खूप महत्वाचा आहे. अँड द कन्सल्टंट अँड सुपर कन्सल्टंट डेफिनेटली त्यांना आता आजचे गाईडलाईन जे आहेत सरांनी रिसेटसाठी दॅट विल बी रिअली हेल्पफुल फॉर द ट्रीटमेंट पर्पज.
थँक्यू सर. समरायझिंग खूप छान समराइज केलं. थँक्यू.
येस. सो आजचं आपलं सेशन आहे. इट वॉज ऑन अ व्हेरी युनिक सब्जेक्ट. मी परत म्हटलो मगापासून, कारण आपले कार्डिओलॉजी, हायपरटेन्शन, डायबेटीज याच्यावरती नेहमीच CME होत असतात, वेबिनार होत असतात. पण दिस इज अ युनिक सब्जेक्ट जे आपल्या डे टू डे प्रॅक्टिस मध्ये बऱ्याचशा ANC येत असतात आणि त्याच्या आपण जेव्हा ब्लड टेस्ट करतो तेव्हा TSHच्या लेवल या आपल्याला किती पाहिजे, टार्गेट किती पाहिजे हे आपल्याला बरेचदा कन्फ्युजिंग असतात. तर आजच्या सरांच्या लेक्चरमुळे आपल्याला डेफिनेटली एक गाईडलाईन मिळालेली आहे की नक्की काय आपल्याला करायचंय, कुठल्या क्षणाला पेशंट रेफर केला पाहिजे आपण, किंवा आपल्याला त्याची पुढं सुपर इंडोक्रायनॉलॉजिस्ट कडनं त्याचं ओपिनियन घेतलं पाहिजे. आपल्याला आजचं लेक्चर कळलं. सो थँक्यू व्हेरी मच सिद्धे सर. आपण भविष्यात सुद्धा आय थिंक वी विल टेक फ्यू मोर सेशन्स, नॉट ओनली ऑन thyroid disorder, but you are masters in endocrinology, so we'll have some sessions regarding the diabetes management for the family physicians and the consultant and for all the doctors.
Sure sir, sure.
Yeah, thank you very much. So over to Dr. Mohite sir for summary.
Thank you.
मोहिते सर म्यूट आहे तुमचा आवाज. म्यूट आहे, माईक म्यूट आहे.
हा, ओके. सर अतिशय इन्फॉर्मेटिव्ह छान सेशन झाला. जनरल प्रॅक्टिशनरना एक बेसिक गाईडलाईन्स मिळाले की जरी अगदी फार कॉम्प्लिकेटेड पेशंट हाताळत नसले तरी सुद्धा एक फॅमिली फिजिशियन म्हणून ओपिनियन साठी पेशंट येत असतात. बऱ्याच प्रायमरी लेवलवरती एएनसी जीपींच्याकडे असतात आणि अशा वेळेला अर्ली टाइम जर पिक झाला पेशंट तर निश्चितपणे पुढचे कॉम्प्लिकेशन आपण टाळू शकतो. तर ह्या शॉर्ट सेशन मधून का असताना तुम्ही छान माहिती आपल्याला दिलेली आहेत आणि अशाच आणखीन डायबिटीस रिलेटेड असो हार्मोन रिलेटेड असो आणखीन आम्हाला तुमच्याकडून माहितीची अपेक्षा आहे. तर
नक्की.
तुम्ही एव्ही मेडिलाईनला कनेक्टेड राहत आणि आम्हाला मार्गदर्शन कराल अशी मी अपेक्षा धरतो.
नक्की.
तर आता काय नवीन मेंबर ह्यामध्ये आज काही जॉईन झाले आहेत त्यांच्या माहितीसाठी सांगतो की एव्ही मेडिलाईनच्या आताच जे रेकॉर्डिंग आहे आणि युट्यूब वरती अवेलेबल तुम्ही पुन्हा पाहू शकता. त्या डिस्क्रिप्शन मध्ये सरांच्या बद्दल डिटेल आपण माहिती देऊ. त्याचबरोबर एव्ही मेडिलाईनशी कनेक्ट राहण्यासाठी नंबर नोट करून घेऊ शकता 9503315933. ह्या नंबरवर तुमचं सेंड करा. तुम्हाला इन फ्युचर जे काही वेबिनार्स असतील टॉपिक्स असतील त्या संदर्भात तुम्हाला माहिती मिळत जाईल. आणि मला वाटतं अतिशय छान सेशन झालं. बऱ्याच जणांची काही क्युरीज असतील पण तुम्ही आम्हाला टाकू शकता. आम्ही सरांच्याकडून त्याचा आन्सर घेऊन तुम्हाला फॉरवर्ड करू. सर तुम्ही खूप छान वेळ दिला आम्हाला त्याबद्दल पुनश्च एकदा धन्यवाद.
थँक्यू.